Hello, everybody. Welcome to this week's Facebook Live. I hope everyone's doing well. I'm using a little bit of a different format today, so I hope you guys enjoy it. Today, we're going to be talking about spinal stenosis. What is spinal stenosis? What is involved in spinal stenosis? What are the different treatment options? And most importantly, when is surgery necessary and when can it be avoided? So these are the things that we're going to be going over today. If you have any questions, please feel free to comment. I'll try to answer all questions as we go along. Or if you have any questions about your personal condition or situation, then you can always DM, comment, or email us at info@fxregencenter.com. And if you do enjoy this video, then please like, share, and spread the word. So we're going to get started. Today I'm going to use a little bit of a different format, so bear with me. I really wanted to share my screen and show some pictures and some images like I did last week, but I wanted this to be a little bit more interactive. So what I'm going to do is describe to you first and foremost what it is, what the spine anatomy is like, and then explain from there what is spinal stenosis and what we often need to do. So first and foremost, what's the spine like? You know, I've gone through these analogies in the past before. I've shown you models and everything, and basically one of the main models that I've used in the past, or one of the main thoughts that I've used in the past, is that the spine is like a stack of coffee mugs on top of each other. So what do I mean by that? So when we look at the spine, I say that it's like a stack of coffee mugs on top of each other, right? So if we look at, that's my nice little coffee mug, I hope you like it. If you have a coffee mug there, the spine is like a stack of them, right? So let's just do a little bit of this, let's do a little bit of that, and and here's my coffee mug on top of the next. Fancy. All right. So this is what the spine essentially looks like, and really what it is these coffee mugs are kind of curved like so. Right? And these coffee mugs are funky, right? There's these coffee mugs here stacked on top. This is the front of the body, this is the back of the body, and in between the coffee mugs there are water balloons completely filled with jelly, and those are the discs, okay? And when we're teenagers, these discs are completely filled with jelly. They're nice and cushiony, and basically they're shock absorbers, right? And these things are completely filled, nice and cushiony, provide support between the two segments. In the back of the spine, where the handles are, where one handle touches another handle, those are called the facet joints right here, right? And so each of these coffee mugs is held on to the next by the water balloon or the disc in the front and the coffee mug handle in the back. Now, up and down, there is a central canal that contains all of the spinal nerves that are traveling up and down, and these nerves actually exit out of the spine in between these coffee mugs, in between the handles in the back and the disc in the front. Now, so basically the hole that contains these nerves is bordered by the disc and the facet joint. Now, when we look at this three-dimensionally, this is a side view over here, but when we look at it front to back or up to down, we can see that there's the disc that's in the front of the body, right? This is the front, this is the back. This is the central canal that contains all the nerves, and these are the facet joints here on either side. In between the facet joint and the disc, that's where the nerves exit on either side and go out of the body. In the low back, these nerves are the things that go down the legs and are in charge of various different things down the legs, right? So the nerves carry signals back and forth from the legs and to the brain. They carry sensation signals, they carry pain signals. They also carry signals to the muscles, which then will move, and that's how we walk, or that's how we grab things, because the signal comes from the brain to the spinal cord, exits out the nerves, and goes down to the muscles. Now, in a normal, when I say normal, in a young teenager, essentially, before we start getting degenerative changes, the disc is nice and cushiony, the facet joints are nice and smooth, and there's plenty of room for the nerves to exit on either side, plenty of room for the nerves to travel in the middle of the spine here. But after the age of 20 or 30, we all start to get these little degenerative changes. So what takes place? This water balloon starts to get a little less water in it. Instead of being nice and cushiony, it starts to get a little bit more wobbly. And as that occurs, there's some more motion that takes place between the vertebral bodies, and there's more shear that takes place at the disc. That by itself, that's disc degeneration, that by itself does not equal pain. It's very common for us to have disc degeneration and have zero pain associated with it. But as that disc starts getting wobbly and there's more motion that takes place there, there ends up being more friction that takes place at the facet joints, right? Where one vertebral body's facet joint meets another, or where one coffee mug's handle meets another, there's more friction that's going to take place there. And over time, that's going to start getting rougher. The smooth surface called the cartilage starts to wear away, and then the bone starts to get a little rougher in that area. Over time, as that progresses, that bone is actually going to get bulkier. That bone is going to get bulkier. The size of the bone is actually going to increase, and that ultimately is going to decrease the space where the nerve is traveling. Similarly, if this balloon is starting to get a little bit more wobbly, if we put pressure on one side of a balloon, what happens? That balloon also bulges outwards. That will likewise narrow the space where the nerve is traveling. So that narrowing of the space where the nerve is traveling, that's called stenosis. Okay? Stenosis refers to narrowing of where the nerve is exiting. There's two types, right? Where the nerve is exiting right here, or stenosis can occur in the central canal in here. So where the nerve is exiting or the central canal, then that's called central stenosis if it's in the center, or foraminal stenosis if it's on the outside where the foramen or the hole is where the nerve is exiting. So all in all, that's the gist of what stenosis means. Stenosis means that there's narrowing of the space where the nerves are traveling, and that allows us to get those nerves irritated in one way, shape, or form. And I'm going to show you some examples of what that might look like. I'm just going to get rid of some of these pictures here and show you an MRI of the low back. Now in this MRI of the low back here, we can see that there's a few different things that's going on. Number one, just to kind of identify things again, here are the coffee mugs, and here are the discs in between, the water balloons in between. Here's the central canal where the gray lines are all the nerves that are going to exit on either side. Right now we don't see a great view of the coffee mug handles, but essentially the coffee mug handles are right here. And we don't see where the nerves are exiting on either side because this is a cross section right in the middle of the body. But what we do see is this central canal. When we look in this area here, this disc is fairly flat, right? When you look at the back of this disc compared to the back of the coffee mug on either side, that's relatively even with the bone above and below. So it's not encroaching on, or it's not getting into this central canal here. So there's plenty of room for the nerves to be traveling in this central canal over here. But as we get over here, you can see that this disc bulge is increasing, and that narrows the space for the central canal. And the same thing occurs over here. In fact, it's much more narrow over here. But here's the interesting thing about this picture is we have this disc bulging going on over here, but you see there's actually some bulging going on this side as well. And you see that significantly over here. So what is that bulging? You know, that bulging is taking place basically in between the coffee mug handles. What is that bulging? There's not a disc in that area, but what's there is what's called the ligamentum flavum, this thick ligament that borders the back of our coffee mugs. So just to kind of show what that looks like here, right? When we look over here, here are our coffee mugs, and here are the coffee mugs here. This is the central canal is behind these handles here, if you can see. Here are the facet joints, and really bordering that is this ligament that connects these coffee mugs together. So what is ligament? Ligament is the soft tissue that connects bone to bone. And you know those thick rubber bands that surround broccoli in the grocery store? That's what ligaments are like. So they're strong, they're supportive, but there's some stretch to them. Now, if you have this, these discs that are starting to get more wobbly, and there's more motion that's taking place between these coffee mugs, those ligaments, the duct tape, or those thick rubber bands that connect bone to bone here, those are going to start to get more stretched. So you have these ligaments, these rubber bands that are connecting all of these together, and those will start to get stretched. As that stretching occurs, those rubber bands will actually start to kink down on one another. So now, if you can picture that, what that is like, you have those vertebral bodies, the discs in between, right? And ligament connecting these coffee mug handles together, for lack of better words. This ligament, as this motion starts to take place here, this ligament is actually going to get looser. And as that stretches, it's going to kink down on itself. And that's going to cause narrowing of this space where the nerves are traveling. Similarly, if this disc starts to bulge, because we're putting more and more pressure on it, right, that further narrows the space where the nerves are traveling there. And that is what contributes to what's called central stenosis. Okay, I'm going to show you another example of what stenosis looks like with a patient of mine. So this is a cervical spine, or a neck. So as we can see here, this is the front of the body, this is the back of the body. This is actually the tongue over here and the mouth. Here's the brain up here. These are the squares, the vertebral bodies, and in between are the discs. This is the central canal, where the white is the cerebrospinal fluid that goes up and surrounds the brain and surrounds the gray spinal cord. And down here, when we look over here, again, we don't have a significant amount of disc bulging. We have plenty of room for the spinal cord here. You see some disc bulging occurring in some of these areas. And you see some of that ligamentum flavum kinking down or bowing in some of these areas. But you see a substantial amount of that occurring up here. In fact, it's so much that you can see that the spinal cord is actually being impinged there. I'll zoom in a little bit for you. Right? So you can see that the spinal cord is actually getting impinged there, and that is much more concerning of an issue overall. So what does this all mean? Now we have to say, all right, we understand what stenosis is. It's narrowing of where the nerves are traveling. So what does that mean? What can we do about it? And when is it absolutely necessary for us to actually, have surgery or have some kind of intervention? What exactly do we need to do? So there's some circumstances that spinal stenosis absolutely needs surgery. When I saw this patient with this cervical spine stenosis, the patient said, you know what, I'm having some pain that's going down my arm, but I'm also experiencing weakness. weakness in my arm as well as weakness in my legs. So when we talk about the nerves that exit our neck, the nerves that exit our neck and go down our arms come from the neck. But if there's an injury or irritation or stenosis that's irritating these peripheral nerves that exit and go down the arms, we'd see symptoms in our arms, but we wouldn't necessarily see symptoms in our legs. So for this patient that was having leg symptoms, the big concern at this point was, is there something going on with the spinal cord, which carries signals to the arms and the legs, and is much more concerning than if it was just the nerves exiting the neck and going down the arms. So in further evaluation, this patient certainly had symptoms of spinal cord irritation, and this MRI pointed at the fact that there was severe stenosis or narrowing of where the spinal cord was. And this was a patient that I said, listen, there's stuff that I can do potentially for your pain, but there's nothing we can do for that spinal cord, and I'm concerned that further irritation or damage to the spinal cord will lead to paralysis. So for that reason, I sent that patient to get surgery. This is a circumstance that surgery is absolutely 100% necessary. So the patient ended up having surgery, and we were able to save his spinal cord, right? He's now still able to walk. He's in physical therapy. He's actually doing really, really well. And he's had some residual pain going down the arm that was due to the nerve irritation of the nerves as they exit. So we actually treated those with orthobiologic solutions using the patient's own blood PRP injected into the epidural space, the space that surrounds the nerves. And we were able to calm down the nerve irritation, calm down the pain that was going down the arms, and actually get him to function a little better. Now, he still has some residual weakness in his legs. That's from the spinal cord irritation, and that's going to take some time to heal as he continues to go through physical therapy. So when is it that we want to do surgery? When is it that we have to do surgery? Well, when we have significant nerve damage or pending nerve damage that we need to be concerned about, because if that is something that continues to go in the wrong direction, like I said, that's the type of thing that leads to paralysis. But what are the circumstances where we can avoid a spinal surgery? When do we try other alternatives and try to avoid surgery for stenosis as much as possible? Well, what it comes down to is there nerve damage going on? Is there room for improvement without having to go under the knife? That's really the question that a thorough history, physical examination, and an evaluation of the imaging is necessary to really determine, are you or are you not a candidate for conservative therapy, right? Conservative treatment. The most conservative treatment that's an option for patients with stenosis really comes down to things like physical therapy, because if we can get the body to move correctly, if we can strengthen the muscles and take pressure off of the discs, and take pressure off of the nerves, take pressure off of the joints, well, then a lot of times people can live with stenosis and have zero pain associated with it. Now, if we do have continued symptoms associated with the stenosis, then that's a circumstance where there are injection treatments that could really be beneficial. So what are the type of symptoms that we talked? We talked about weakness already being something that says, hey, we might need to get surgery sooner than later. But what are the other symptoms associated with stenosis? Well, one of the things that could be associated with is pain going down the legs. So your typical sciatica type picture might actually be related to stenosis. That is found because nerve irritation can cause signals down the legs, even in the absence of back pain. Right? Common to have these symptoms going down the legs, even things just in the foot or just in the calf or just near the knee or in the thigh, and have zero back pain associated with it, because it's these nerve impulses or signals that are carried down the legs and does not necessarily have to do with the back in terms of pain. Numbness or tingling are common symptoms. Numbness like you can't feel, that's gradually progressive. And pain, numbness, tingling, things along those lines that are worse with standing, bending backwards. That's kind of the textbook movements that cause pain from spinal stenosis to be worse. Because in actuality, when you have spinal stenosis and you have these coffee mugs right here, right? If you actually bend forward, right? When you bend forward, or basically bend in this direction here, right? Then that can open up the space for the nerves. So let me show you with the bending forward here. Let me see. So if you took this spine and you bent forward like so, right, that would ultimately make room for the nerves that are exiting over here, and that makes the symptoms feel better, versus bending backwards compresses this area and causes more pressure onto the nerves and more irritation there. It's not hard and fast like that. You can have stenosis and still have symptoms with bending forward, but the textbook way that things occur is if you bend backwards, it causes pressure onto the nerves there. I just noticed that my little logo bent forward too. Looks like those layers were linked together. Hey, trying this out for the first time, so I'm gonna have some errors here, right? Now, there's another thing that's very typical of spinal stenosis. It's a symptom called neurogenic claudication. And what neurogenic claudication refers to is this kind of sensations down the legs that are associated with pressure onto the nerves. A very common presentation of this is cramping in the legs. And you'll hear stories like, hey, you know, I can walk only a few blocks before I start getting cramping in my legs. I have to sit down. As soon as I sit down, the cramping improves, and then I can walk a little further. And as the stenosis gets worse over time, then now all of a sudden, what used to be a few blocks that you could walk now is like 3 blocks, now is 2 blocks, now is 1 block, because when you're standing for periods of time, that's causing more and more pressure onto the nerves. You can get these neurogenic claudication symptoms or cramping in the legs even overnight when you're sleeping. When your muscles relax and you're in different positions while you're in bed, that can ultimately cause pressure into the nerves and cause this cramping sensation. So these cramping sensations down the legs can be related to spinal stenosis as well. So if you're having these symptoms, though, if you're having these symptoms, but in the absence of significant weakness that's progressively worsening, or significant numbness that's progressively worsening, then these might be circumstances where we can try to avoid surgery. Like I said, strengthening the muscles around the spine, taking pressure off the area, and injection treatments may be beneficial. So now the traditional injection treatments for this type of situation involve cortisone injections into the epidural space. Now, the reality is that this is something that may be an option to try, particularly if you're younger or male. And the reason that I say that is because if you're a female, that cortisone injections can, especially as we get older, cortisone injections can potentially increase the chances of things like osteoporosis. I've seen females that were postmenopausal actually get their menses or period back. So there's hormonal changes that occur with cortisone. And the reality is that as stenosis gets worse, there's research now that shows that cortisone injections for spinal stenosis may have similar benefit as if you just injected lidocaine or numbing solution into the epidural space. So why is that? Well, cortisone injection would basically inject an anti-inflammatory, cortisone or corticosteroid, around these nerves to try to calm down the inflammation or irritation of those nerves. But if those nerves are in a narrow space, then they're constantly going to get irritated, so the cortisone only lasts a very short period of time. So an alternative to that we've been doing now with some pretty good success, in fact, we've looked at our data and seeing injections of what I'm about to talk about compared to cortisone injections, or rather compared to looking at the outcomes of orthobiologic injections in patients that had previously had cortisone injections. By and large, they had longer lasting benefit from the orthobiologic injections compared to when they had cortisone injections. So this isn't a randomized controlled trial, but looking at data, looking at how patients have done, we've seen some longer term improvement with using orthobiologics. So what do I mean by orthobiologics? The predominant thing, the common thing that I use for this type of condition, for stenosis, is using a patient's own blood PRP. PRP, as you might recall from my other videos, stands for platelet-rich plasma. The platelets, when you cut yourself, the platelets are the thing that stops the bleeding. Those release growth factors that then cause inflammation and take inflammation away. Some of that inflammation that's caused is by calling local stem cells to the area, because we have stem cells throughout our body. And that PRP, or platelet-rich plasma, can strengthen soft tissue structures and can actually heal certain things such as nerve irritation or nerve damage. In addition to calming down inflammation, we've seen patients that have had nerve injuries actually have improvement of their nerve injuries and actually have improvement of things like their strength. So in this type of situation, though, it's not enough to just inject into the epidural space. Why do I say that? Because injecting into the epidural space would calm down the nerve irritation and potentially help with those nerves, but really is not doing anything structurally for this area. And then we'd end up having the same kind of outcomes as we would with an epidural steroid injection. But since we're using an orthobiologic that has the potential of strengthening things like ligaments, when I treat a situation like that, I inject into the epidural space to bathe all the nerves as they travel through this area. I also inject in a manner to coat the exterior of the disc, because as we saw from last week's video, we have seen disc bulges decrease before with these injections. I also inject directly into this ligament here that is getting looser and that is kinking down. I inject into that ligament as well as all the ligament structures that are connected to that, with the attempt to try to strengthen all of that, to try to take some pressure off of the nerves back here. In addition, since arthritis in the facet joints are a component of what's going on in this circumstance, I also inject into the facet joints at the area of the stenosis to try to A, calm down any inflammation or irritation associated with them, but also B, try to provide some stability, try to provide some strength to those joints to decrease some of the motion that's taking place there, and again, therefore take some pressure off of the nerves in their narrowed environment. By treating what's called the functional spinal unit, by treating all aspects of this, we're oftentimes able to get A, significant benefit to symptoms, but B, also longevity, right? Because we're strengthening things around that area to try to take pressure off of the nerves. You combine that with the appropriate nutrition, hydration, and exercise to get the body moving correctly, then that ends up being a long-term success, and we're oftentimes able to avoid surgery. Now, so long story short, spinal stenosis is something that involves the low back, the neck, the upper back, any part of the spine where the nerves are traveling. Spinal stenosis involves narrowing of where the nerves are traveling, and that could be multifactorial. That could be caused by disc bulges, facet arthritis, ligaments getting looser. Various different things can cause pressure onto those nerves. When there's a significant amount of narrowing and there's nerve injury taking place, particularly if it's in the neck or upper back where the spinal cord is, and there's a risk of something like paralysis, that's the circumstance where surgery is absolutely necessary. But in all other circumstances, when we're not dealing with nerve damage, then we can often try to avoid surgery with physical therapy, the proper nutrition, as well as injection treatments. And based off of my experience and the data that we've seen so far, using the orthobiologic injections to calm down inflammation of the nerves and to potentially strengthen some of the soft tissue structures around the nerves, that ends up getting us longer term benefit and overall a safer alternative to cortisone injections. I hope this all made sense. If you have any questions, again, feel free to comment or DM, or you can email our education center at info@fxregencenter.com. If you found this helpful at all, then please like it, share it. If you didn't find it helpful, or if you don't like this particular format with me drawing on the screen and all that, then you let me know so I can revert back to just seeing my pretty face or just seeing the screen. But let me know what you guys think. Hope you guys have a great Friday and great rest of your weekend. I'll see you next week.